You hear a weird sound like a squirrel mixed with a weasel.
It's Daniel.
I was going to say, why does Daniel sound like a squirrel? I say Maddox was just going,
It's funnier if it was Daniel.
It would be. It'd also be a lot weirder sitting right next to me. Okay. I don't know how long it's been.
That's why it's weird.
I should have looked. Yeah, if you're sitting over there, totally not weird. How has it been? I guess I should have looked. I feel like when the last episode was.
I think it was in the end of fall.
I thought you were going to say in the 70s.
No, it was end of fall because we were going to start a new season over.
Yeah, true.
And practice got busy, life got busy.
Yeah.
And here we're refocusing.
We got to make sure that a baby doesn't kill herself over here. So if I have to dive off camera, that's where I'm going. Yeah. So we're going to get into whatever episode of the week in review this is. I think it's 14 or 15. I'll look really quick. But we're going to kick it off with Sloan. Sloan's always going to be
long-winded,
but she's also got to handle the baby possibly. She said she's going to be short, and then she came out with half a novel, maybe a novella, a little shorter than a novel.
It's a short story.
Yeah. So we're going to get her started.
Okay. It's been a bit, but in the last, maybe 6 months, we've had a lot of cool patients at the farm. So I hope that we brought some cool stories for today. This patient came in to me this week. She's a recurring patient of mine. She's a 9-year-old gymnast. I've been working with her just the past few months, and I think I've only actually seen her maybe once a month. So I think this was only our 3rd visit together, but today was this week was a different reason than she usually comes to me for. What she has been seeing me for was just on improving the distribution of extension throughout her full body. So she didn't have any pain or anything. Her coaches just noticed, oh, you have tight shoulders and a tight back is I'm going to put air quotes around tight back. So they send her my way so that maybe I can troubleshoot. And because they've noticed if we can help improve shoulder flexion early on, it will really limit the amount of low back injuries we have in the gym, which is phenomenal. And I love that they're taking note of that and they send them this way. So that's what we've been working on improving. And we've been doing that the last 2 visits through some corrective exercise progressions, improving shoulder flexion and T-spine mobility. I also noted that she needed to work on some hip extension, but we had not made it to that point in her treatment plan yet. So she comes back in this week. I'm thinking we're going to dive into hip extension this week. That was kind of my plan. Ironically, I wish that we would have been able to dive into that the visit before, because I think perhaps that could have helped the reason that she was presenting in my office this week. But anyway, so she came in to the office with onset of left knee pain. And this is news to me because she's not had pain this entire time. So she started having acute onset of left knee pain a couple weeks ago, and she went and saw an ortho. Let me just take a second because Beau's only given me 10 minutes. So I get 1 second to make this side note. Just something personally that I think that I need to work on, and that I think that this would be good just throughout our profession in general, is I really need to work on educating the public, but also my current patient base, that we're entry of level. We can be a great point of triage for musculoskeletal ailments. So I see this gymnast to improve movement patterns. However, they went to an ortho with her knee pain. And you don't know what you're talking about. You're just a chiropractor. I'm just a chiro. You're right. But I mean, all joking aside,
I don't even know. I could have. This is all just magic.
I could have been that point of triage for them. And selfishly, I wish that I would have been. But nonetheless, they're at my office now because that ortho created a PT prescription. And they said, you know what, we want to do this with Dr. Sloan. So I'm grateful that they did come back this direction. So her left knee pain, they did get an MRI. It confirmed Osgood-Schlatter, and then Larsen-Johansson syndrome. Thank you. And if you guys have been a follower for any amount of time, you may remember one of my previous gymnasts that I worked with that had this complaint or had this syndrome, and it was a new one for me. So when this presented again, I was like, boom, I know how to handle it this time, So if you're unfamiliar with that, it's basically an apophysitis or a separation of the growth center at the lower or the inferior pole of the patella. So she's got injury to the growth center of the tibial tuberosity as far as Osgood goes, and then the inferior pole of the patella.
Which I think is impossible.
It does seem theoretically kind of hard to have.
Where are you pulling from?
Right. You have to have a source of leverage there.
Yeah.
Do we have our images?
I have not seen the MRI itself.
Yeah, I question.
Yeah, but the reason they went on from X-ray to MRI was to confirm that it was Cindy Larson and not a fracture. So I have not seen the images yet. She was just here 48 hours ago, but I'll show you kind of through my exam why I question that as well. So I'll get there. So her PT prescription was 2 to 3 times a week for 6 weeks, which we can all kind of question that in itself. But let's go back to the fact that she was 9 years old, right? These kind of injuries occur kind of during growth spurts. She just increased practice time from 16 hours a week to 20 hours a week for the summer. So it really, it's consistent with her age and increase in practice time. Here's what the ortho prescribed. Motrin every 4 to 6 hours. Continue practicing gymnastics according to pain. So he did not restrict her from any sort of movement or any sort of like jumping, running. He just said, as long as it doesn't hurt, you can do it. If it hurts, step back some. Heat before, ice after, and then wear a Chopat strap. He wanted to do all of this to, quote, stay ahead of the pain. So my exam, and I'll admit my exam was probably far too simple and like far too short, but I
The case report won't be
newsflash. How many minutes do I have left?
2.
90 seconds.
The brace. Is there any research to back that? If you look,
I can't tell you, but I will tell you
Chopat?
I have a problem with it
for this
right
in
now.
particular.
I mean, it's kind of cut. It creates a mechanical advantage for the
It
tendon.
creates
but
2
now-
levers rather than one long
Yeah.
one.
But like,
But do you want a mechanical advantage for a 9-year-old? And I'm going to get to that.
And for this
If you
so-called
can-
diagnosis.
Yeah, if you can stay with me. Okay, so exam, probably too simple, but going into it, I kind of had my bias of where I wanted to go with my visit with her. Visually, she clearly had swelling over the tibial tuberosity. With her gait, I was just looking kind of surface level. She had no disturbances noted. Like she was not limping. She was not demonstrating that her knee was hurting at all. It was tender to the touch upon palpation at the tibial tuberosity, as well as really hot. Like it was absolutely warm to the touch. However, there was no pain on the inferior patellar pole, like none at all. So that kind of made me question that Cindy Larson diagnosis as well. All other knee ortho exams were completely negative. And then you could not provoke her knee pain at all with any sort of movement. So no functional assessment, like squat, jump, all of that felt absolutely fine. I want you also to note that she's continued practice because she's no longer experiencing pain. So she went from having this acute flare that was so bad that she could not do gymnastics to now she's doing all of her practice because it's not hurting. So it brings me to this kind of ethical, philosophical question. We have a 9-year-old in front of us that clearly has an acute flare of Osgood. Is it appropriate to treat pain in this instant? Or do we allow the body to kind of do what it's doing? So I just listened on the way here to Beau's newest YouTube video on the farm YouTube channel. And it was really good timing because it was absolutely kind of related to my thought process with this case. I really struggle with this. It's kind of a philosophical question or a thought process that Beau and I have talked about a lot over the last year when we're treating kids, young athletes. And is our objective to treat pain? And I don't think it should be. We should definitely evaluate what their goals are and align our treatment to their goals. But at 9 years old, their goal at this point isn't, I'm competing at the Olympics this summer. Their college scholarship isn't riding on the line. The rest of their life isn't riding on whether they can do practice this week. And so I think where, I hate to say this, but I think where the ortho got this wrong is that quote, he said, staying ahead of the pain. If she were to experience pain, I think that would guide her better as far as what she should and should not be doing at gym. I don't think that her Osgood apps like healed over the last 48 hours. I think that she's masking it with Motrin every 4 to 6 hours. ice and heat, using the Chopat strap to create that 2 levers versus 1 long lever over the patellar tendon. And I think there was one more thing in there that he wanted her to do for pain relief. I can't recall. So when she's sitting in front of me at my office, what do I do? Because legally and according to my scope, am I allowed to address the Motrin? Are we allowed to address the Motrin?
I don't know, but I do all the time.
I know it's hard, right? It's hard because legally I can't say you shouldn't take. I can't
No,
go
you
against.
can absolutely say that it's contraindicated for apophysitis.
I can apply. I can tell her what
That's called science.
research and the science says, but I can't say don't do what the orthopedic said to do. And professionally, like, where am I to stand up against that, right? So I can supply the information and the parent can do what they want with that. But I kind of went on the line and I said, hey, this is why I think pain is a really good thing right now. Pain will be her thermometer of what she should do. Pain will be like her gauge. And her season isn't for another 2 months. Would we rather cover this up? You know, Osgood isn't like a come and go thing. Osgood, I think according to a textbook, says it can stick around for what, like 2 years or something. Like Osgood can become this very chronic issue. And if we were just to take time right now and let her listen to pain and use that to assist us in the modification of practice and the modification of performance and then add rehab to it, I think she's going to be way better in the long run than if we were to mask that pain right now and push her. And then we're going to get into season and she's going to start having knee pain again because she's going to be doing the repetitive skills on hard surfaces. And we're just going to have to do palliative care until she's done with season. So I kind of wanted to pick y'all's brain if you'll give me the time to about where you stand with this. Where are we at time wise? What does that say?
Thumb game.
What does the time say?
I think we're
Was
in
it
2022.
No, was it 20 minutes?
No, I don't know.
What was your question?
No, like where do you stand with that? You know, you've got a patient in front of you. I'll tell you, when I first start the first year of practice, I would have been like, let me throw all of my tools at you. I know that you're going to walk out of here. You're going to have no knee pain. I'm going to do all the tricks, if you will. But really, I don't think that's what's best for that patient sitting in front of me.
Either.
No turning tricks at the
I
farm.
don't think that's a good thing.
I think you kind of treat it as in like Daniel Hahn would say, or Dr. Hahn, as in, does it pass a who cares test? And I say that as in like when she has pain, is whatever movement, rehab, whatever I have her doing, whether it's gymnastics to go back 100%, is that causing her pain? And then hopefully all my like functional audits will tell me or show me why she had knee pain, whether that's actually what the MRI showed or not. Mm-hmm. And then I'm going to go through rehab regardless. So it's like, I'm going to continue to like load it. And then like, for instance, I'll give an example. Like I had a patient today who had Maine syndrome and like she kept messaging me in our new app. You haven't downloaded it. I guess this is you can download it.
Good plug here.
And, but she was just telling me about how she had pain and it was talking to her. And I was just like, okay, like it doesn't matter to me. For like if we kind of think about like tissue preparedness and like loading that tissue, like
but I do think that Maine syndrome is different in kind of nature than a very acute, visible, swollen.
So like okay, so my
presentation.
baseball player who had Osgood, bilateral, and I remember we were trying to bring down his pain, but we kept caring about what is his hip and his ankle, what is everything doing as far as it takes to the baseball field. And performance. So like, that's how I guess I would approach it for gymnastics. I was like, what is everything else doing as far as her performance goes? And is that doing what we want it to do? And if it's not, we got to work there.
I know. And the other question I had for myself is she's seen me after she's taken 6 doses of Motrin. So I'm not getting an appropriate exam in the first place.
Yeah.
So I'll get back to the parent eventually said, you know what? Yeah, I think you're right. I think I want to back down on the Motrin and just see how she responds. Maybe she has no pain without the Motrin. Great. Maybe she has no pain after icing and taking the icing, the heat, and the Chopat strap away. If that's the case, then wonderful. Then we will begin to do some really great rehab with it. And what I do want to do next visit after she takes some of that palliative stuff away is I want to dive into the movement more. I want to be a little bit more nitpicky about gait and jumping mechanics and watch some actual gymnastics videos of her and see why she presented with this. Is it just simply growth spurt and increase in gymnastics and increase in practice hours, or is there something underlying that we could work on?
And I think is what's great is I remember having a conversation with you one time about kids, and I was just like, Sloan, you could teach the class on bedside manner. So like, how would you, I know this, we had this conversation and, because I was talking about like a pitcher getting back to throwing. And then you said, you act like you're the parent and you say, what are your long-term goals?
Yeah.
And then it's just like that I'm treating according to that.
Yeah.
Yeah. But you can't act like a parent, because if you're a parent, you don't want her to hurt. So realize what the parent's doing is absolutely what you would do. You would not want her to hurt, even if you have the knowledge base of function, rules, pain. It doesn't matter who you are. If your kid's hurting, has a tummy ache, whatever it is, you're going to do whatever you can. That's what the parent's doing. So what we have to operate from is a different guise of, is what's affecting her going to affect her sport and cause a different injury? Basically, protagonize the injury at hand, right? So then if it's a golfer, that's way different than gymnastics. So are we just saying, well, we have to not do anything because of this, or is it, the demands of either gymnastics? Now we set her up for a patellar tendon rupture, especially if they're actually saying that an MRI says both sides of the tendon are irritated.
Yeah.
High risk, right? So then that's where it's like, yeah, we take her through an exam. You determine like, oh, she can't do X, Y, Z. And here she's out, right? Oh, you can do everything because there's no pain, which then leads us to believe that you can have an acute inflammatory response with not a lot of pathology behind it, right? Due to growth spurt and just demand. But I just think it gets down to like removing yourself from the scenario of the parent wants to get rid of pain. We obviously know that's a bad thing. So don't get stuck in the mindset of, okay, let's see if she's out of pain with the Motrin next time. That's not our goal. Just because she's out of pain next time, even though she's not taking Motrin, we still have to adhere to the rigors of what can she do? What can't she do? Has that changed in the face of pain? Because pain will change that. Right? If your knee hurts, you can't do certain things that would look like you're dysfunctional when it's really, oh, you can't do a single leg deadlift or a single leg squat because of that. So I think just like stepping away from the pain model is hard to do, but like that's kind of her job. Right?
Well, I think I say like the parent thing more as in like, all right, is this Trip or is this Maddox? And then we're looking at it from like our eyes and our child. So we're looking at it from like a doctor's and a parent's mindset, not just a parent.
Yeah.
So kind of like almost like what you and Sloan were saying together.
Yeah. And I would say wait for all of us that have kids to wait till they're in that scenario.
Right. Yeah.
Because it's like, if your kid's doing a sport, is hurting, you want her to play the sport and not be in pain. We haven't been presented with that personally. And I know what I would have done as a kid.
Yeah.
I know more than that now, but then it's my kid. And now I'm like, it's going to be tough, especially if they want to play. Right. And then it's this whole, like, that's a different dynamic than saying like, well, I know what the science says, you know, and hopefully you do adhere that as a parent. I think that's kind of your job. Like if, you know what I mean? Like, hey, but if your kid's crying and Motrin makes it feel better, that's going to be tough.
I laugh because I think when I was in middle school, I was told by a guy, he was a senior who ended up winning state championship. And we were talking about like school and grades, which, you know, I would never tell a kid this nowadays, but he said, nobody's going to remember if you made an A or a B in that class. They're only going to remember, did you get that ring or not? And so when you think about pain and all that, like I know as an athlete, I would have pushed.
I think that's on Varsity Blues.
I would have pushed through.
Yeah.
I want to throw out there, I have zero blame in the parent in this situation.
Yeah.
I can't imagine Maddox in pain, and I would want to do anything possible to get rid of that.
I think the real thesis of the whole case study is the MRI findings may not match the exam findings, but there is acute inflammatory signs. So that's a hard, so let's take the flip side of the MRI shows that no acute inflammatory scenario, which you're going to see all the time, right? Yeah. Now what do you do? Because now it's, oh, they have less pain. The MRI showed this. I don't see any inflammation. I think all of us would lean more to, you can keep going.
Yeah.
You see that acute inflammatory sign, but you're a doctor. Okay.
Right.
We got a couple things going here that are like more risk to just go than to not. I'd call it the ortho on that, like acute inflammatory signs, giving them Motrin, which is contraindicated for apophysitis, and then telling them to go is not the best advice in the world. If you give them Motrin, tell them to take time off, or, you know, one or the other or something like that. Yeah.
I'm glad we had this conversation because I I think all of us probably would have ended the visit pretty similarly, but we might have just gotten there a little bit differently. But
Yeah. Who's up?
don't worry, Maddox is like doing a balance beam routine over here.
I'll go. I'll make mine short and sweet because if I think we're already over 10 minutes. So mine's more of a initial patient reaction and interaction. So a couple of months ago, I had a man who walked in who had a total hip replacement in 2019. So he comes in. He had a buddy. He is in his 50s. I can't tell you exactly.
He's pretty young for hip replacement.
Mm-hmm.
Right. Yes. So he came in. He had a buddy who told him basically right after he had his post-op PT to come here. You know, like anybody who has not heard of the farm, like at least in Birmingham, they're gonna skeptical. Like, why should I go in? I'm not going to.
It's called the farm.
Yes. So he comes in and he tells me that he has been recently told in the last month that he has heterotrophic ossification going on in his hip after his hip replacement, and that they want to go back in and clean it all up. And he goes, he just looks at me dead in the face and he goes, is there anything you can do? And I think the one thing that's great, like about like watching Beau so many times is I'm like I don't know, we'll see. That's literally what I said to him. I was just like, I don't know. I don't know if I'll make it better. And I was just like, I have to load it to find out. And like, he's kind of like a bit of an attitude, but this whole entire time, like, why am I, like, it's almost like that attitude of like, why am I even here? And so I'm like sitting back, like cross my legs, leaning back, like being like, so he looks at me and said, have you ever seen a total hip? And which we have. And then he says, have you ever seen one with HO, or like that's what he was calling his heterotrophic ossification the whole entire time. And of course I told him I had seen it. Had I seen it? No, but he doesn't need to know that.
He just wrecked his car into a telephone pole. It's like, oh, get lied to me.
Yeah. And so because in my mind, I keep thinking like, I won't know if I can help this man at all unless I go load him. So he says, okay. And I go, let me do an exam. And so I kind of watch him move a little bit. I don't even know if we did the full SFMA. But I get him like doing like a sideline 5-month loading his hip. And it's funny. I load him on his hip and he immediately gets up and he goes, hold on, let me just walk around. And I'm thinking like, what in the world? Like this guy's had an attitude the entire time.
For people listening, when you say load, you're saying DNS. I'm assuming.
Yes. Loading DNS 5-month sideline. And I'm like, what is he doing? And he walks around the table and he goes, this is the best it's ever felt. Okay, I'm bought in. I'll do whatever you want. And so long story short, like
had him pay up front $5,500.
$5,500.
Huge treatment plan.
10-year treatment plan.
144 adjustments. I still haven't adjusted them yet. But like I just kept looking at, I mean, you know, I don't say in my exam, my functional audit, my pain audit, all of these different things, because like my exam, everything was positive.
Yeah.
My functional audit, everything, you know, my pain audit, walking, I mean, moving, anything except for swimming was painful for him. And I looked at him and, you know, basically I educated him and I told him, I go, you haven't loaded it, you haven't moved it. So of course bone is going to grow in your hip if you don't load it. Like that's your joint's responsive way of saying, hey, I'm going to get more stable. It's going to get more stable by adding more bone. So I looked at him and said, we don't really care what an MRI would look like in a month from now. We don't care what it would look like 5 years from now. I just said, but I mean, like this last visit I saw him, I said, it'd actually kind of be cool to see what it would look like. Mm-hmm. But then I also followed that up with saying, but we won't care because we care about how it functions. And so
we care about something more.
Yeah, we care. And so I said, hey, you just want to get it moving. You just want your function to change. And literally has been like, since then, like he loves everybody in the office. Everybody in the office nobody was in the office with me on that first treatment. So like nobody would know that he was like that on his first visit because he's been nothing but nice. Heck, we don't usually let dogs in here.
was that
And
guy?
Oh,
like,
it's that guy?
yeah,
Ah,
but like,
that dog was really
puppy.
cute.
I mean, adorable. If you didn't know a golden retriever and a King Charles Cavalier could mix and make the most adorable puppy outside of Groot, my dog, then
It is a really cute puppy.
it's adorable. And he's brought it in, just like loves everybody here. But it was all kind of like we're gonna see, like, and then just like sometimes telling a patient, hey, I don't know how things are gonna go.
And the cool thing is he's out here before he goes into your treatment room doing a bunch of the extra. So I made fun of him the other day, and I didn't know that was this guy, but I was like, oh, you're warming up. He goes, gotta do my stuff. So
Yeah.
like he's dedicated. So that's cool because obviously that's showing there's even more buy-in.
Right. And so like, we have him doing everything. Like if you're looking at treatment, obviously we had him 5-month sideline day one, but we have him everything from like loading his hip, kind of watching roughly how far we take a total hip and like abduction. But outside of that, we're moving his hip, we're loading his hip. Like he's doing everything from like 5-month McKenzie, like plyometric stuff nowadays to keep reinforcing, hey, this is like, you're playing long-term game now.
Yeah. So I'm curious because with those people that are skeptics up front, what I'm always worried about, it's happened to me a few times where you get a whiz bang result, right? Like dude gets up off the table, walks around, and then like prolonged, right? He's still doing better, obviously, but like 2 years from now, right? Because like that hip has had major changes morphologically. So did you ever have the educational talk of like, your hip, on MRI structurally isn't great. Like the chance of like it flaring up, getting worse. Like, did you address that up front? So in case he hits that, he's not going, now it's like he's had this double kind of smack of skepticism. Like, I was doing better. I did this thing and it's just like terrible again. And then they really fall off the deep end.
Yeah. So I don't remember if it was after he was already in a good mood day one or if it was visit 2. It was one. I think it was visit 1 though, that I kind of explained to him, Andrea Spina's FRC, like bioflow, like how tissue was even created in the first place.
Mm-hmm.
And so I looked and like, that's been kind of where I've been like, hey, you're looking at like tissue change.
Yeah.
Like this is not easy, but you got to keep loading. And like, even today, he's a guy who's convinced that he wants to come twice a week, but he works out of town. And so he comes back-to-back days. And I looked at him and I go, hey, we're not actually going to make much difference those 2 visits. And so I kind of looked at him and said, you just like, I'll see you once a week, but like and like the past 2 visits have been a really good example. Like he comes out here, starts to work. It's almost what I think we would all want all of our patients to do. Like come in, go ahead and start to get to work. And then it's just like wonderful. Like you're doing what you're supposed to. We know you're doing your homework. We're trying to create these long-term changes. And like, that's only going to happen if you know how hard you have to work.
I think there's 2 points there of finding what their buy-in point is, right? He picked up the bioflow thing. If you wouldn't know, you probably would have found something else with buy-in, right? You just would have kept going. Second thing is, I think sometimes we do say, like, I've caught myself, like, say it's a Friday and 4th of July is coming up next weekend and we're treating somebody and I'm like, hey, you got to get in here twice next week. And they're like, well, I can't. And they're like, the only way I could if it was like Monday, Tuesday. And you're like, God, it doesn't work. I need space. Well, I would think of it more like basic training with a soldier now. They only have a month with them. There's no way that like in a month, we know that from physiology that they're like a soldier, but what are they doing? They're trying to like lay groundwork, principles, teach them, educate them. And then they keep doing that for years. I think more touch points with somebody. Yeah. We're not trying to just do it for the business model. We're saying, let's see twice next week so I can get more touch points. Yeah. It's not ideal to have them back to back, but it's better than like one, better than none. So I think like the fact that he's making it work goes to, you and I were talking earlier today, we're not in like the central hub of Birmingham. We get a lot of like, wish you were closer. Well, we don't. Like, come on out here. Like everybody makes it work. People travel out of state. This guy works out of state, he's doing all this stuff. So yeah, I just think use what you got, but also think about like the time you have doesn't have to be like treatment outcomes. Like we're all about education. Well, what else could you educate him on? Right. A bunch of other stuff. And if he's willing to come in, like he's bought in.
Yep. And this is like 2 months.
Yeah.
Where I'm finally like, hey, you're at where I want you to be. And I'm going to keep challenging you. But yeah, and I even though it was back-to-back days, I didn't love it because I'd love some separation. Right. In a perfect world. But
you do want to see what they can do without your interventions. Yeah. Because that is important. And we're trying to not create reliance. However, I think the idea of creating a reliance, we think that if they're with us all the time, that's creating a reliance, not if you're teaching them stuff.
Mhm.
There's a reason people keep going to gyms for years. It's not because they're reliant on the gym model. They like going because the coach, hopefully they're becoming more fit. If they're getting worse at fitness, they wouldn't keep going to the gym because the results would be diminishing. So I think we beat our profession up of like, oh, you're creating a reliance, or you're creating continual change in different avenues. So if human health is a spectrum of like, 20 different touch points, good luck doing that in like a lifetime. And then stuff falls off. This guy go through a stressful work period, his hip may get worse, his diet gets worse. Like there's always stuff you can be working on. And we're not, again, trying to milk people for money, but like there's a reason that we're, talking about all this stuff.
Right.
All right. We're going to wrap it up with our slugger last. So I'm going to go next. Home run here last. All right. So this is a fresh case. So I saw her twice this week. So we got a first initial and then a little bit of follow-up yesterday. This is a 49-year-old female. She's a nurse practitioner. I say that because she's coming into it with a medical mindset. Chief complaint of left plantar pain and dorsum of the foot pain, kind of pain that moves around her foot. And you'll kind of understand why here in a second. Been going on since January, dealing with almost constant left foot and ankle pain that started during they were moving houses. So she kind of told me that like, hey, I was picking up a bunch of furniture. I was, doing all this heavy stuff. But at the same time, she started running a little bit more because she is a gym goer, like spin class, I don't know what you're going to call them, like cardio HIIT classes stuff. But she started running more around their new neighborhood. So it's kind of running was new. She's moving all this furniture. That was the only thing she could think of as far as like novelty within that time frame. And then she said her first approach, she's a nurse practitioner, was rest and NSAIDs, and said no improvement. She gave herself like 10 days, just like didn't do anything, took some anti-inflammatories, no better. She said it was hurting the entire time, like, stop moving, get up, walk around, hurt really bad. Then she sought out a visit from a podiatrist. Over the course of about 4 weeks, she received 30 different corticosteroid injections all around the kind of medial plantar aspect of her foot. Right below the tarsal tunnel. So those were I would say like 10 days apart because she would get about a week relief. It would wear off. She'd schedule a new appointment, go back in.
Holy cow.
During that time, that podiatrist fitted her for custom orthotics. She's been wearing the custom orthotics since whenever that visit was, and I think late February. A month later, since she was having a week relief, it would come right back. That happened after the third injection. She sought out the advice of an ortho who put her in a boot for 5 weeks. And now she's in our office, right? So she's went down this pathway of like rest, podiatrist for a couple months, ortho, boot. And she's not only in a boot, she's in basically a dorsiflexion adjuster boot. So something that you put somebody in post Achilles surgery, and they have it cranked into dorsiflexion because they tell her that she needs to stretch her calf, her Achilles, and her plantar fascia because she has plantar fasciitis. Talk about that in a second. She now reports with pain that is worse when out of the boot, just in general. If she doesn't have the boot on, her foot and ankle ache, right? So my first thought, like I want to put in like my clinical thoughts when I'm hearing this. I'm like, ooh, she likes that parasympathetic hug, right? Like she likes it feels good to have compression on it, which is common. And then she said she had an MRI from the ortho before they put the boot on. So this is almost a month and a half ago, that showed an os peronei with edema around the ossicle, right? Which, might be a benign finding. And then as well as edema within the talocacaneal joint across the whole joint surface, which is not even where pain really is.
But then again, when you almost expect that if she's not getting any movement.
Or that's the only place she gets her movement is we're going to, 100%. One clinical note here, I asked numerous times about low back pain. She said, nope. I mean, I asked you've never had low back pain. Never had low back pain before. Never had low back pain when you're working out. Never had low back pain when you're running. Asked a couple times. No, I think at least 5 times. Nope. Severe history of sleep issues since around 7 to 8 years old. She said that she would wake up 2, 3 in the morning, go sleep with her mom for her entire life. You could, whatever that is, psychologic, physiologic, I don't know. She's been using a CPAP since she was 32, which was extremely young. She's also in the medical field, so prevalence probably led to that side. She had a rhinoplasty and septoplasty age 34, so she was already using the CPAP for 2 years. She still deals with insomnia, and in addition to taking other medications, takes Ambien and Trazodone nightly, and she still wakes up. There's like, can you imagine if you just chugged a bottle of whiskey and still woke up? Like that's this lady. She's like CPAP, tranquilizer, sleep medication, rhinoplasty, sinuplasty, and still just like, what's up?
I drink 2 bottles.
Yeah. Yeah. The dose isn't right. So that last part, I really got into the question, and she did a really good job filling out the medical paperwork because she's in the medical profession. What's the biggest risk factor for females that run for bone stress injuries? Sleep, right? So I was like, and then they're showing edema within a joint surface. It really didn't seem like a joint stress fracture the way that she had offloaded it, but now to boot, it's not getting better. But you can definitely have, almost like a neuropathic degeneration within a joint if you just like, get some sort of like CRPS or claudication going on. So go through the exam now. Top tier, dysfunctional, non-painful, multi-segmental extension, multi-segmental flexion, right rotation. So left rotation is fine. Right rotation looks kind of like it gets bound up around like TL junction, and then bilateral single leg stance is not so great with eyes closed. She could kill eyes open. Gait, decreased ankle dorsiflexion. That's on the left side. Big toe extension and active heel whip, foot flaring on left with decreased hip extension. So now it's chicken or egg. Like she's picking her foot up, turning it out to the side. If you're watching the video, turning it out to the side and then placing it back down. She's probably just getting away from pain. I don't think that's what led to this, but she walks really intentionally around that side now. And then ankle valgus on left and right. Left is worse. So she is just spilling in to literally where her pain is. So we're starting to see some functional stuff. And she is, I'll say at this point, she is out of her boot at home at night, but she's in like UFOs, like big cushy sandals, right? Because I feel good. Palpation, L5S1, extension, lateral flexion restriction. She's a Baton 9. Like she is hypermobile, 100%. Right? We find out later when she's talking about her daughter's hypermobile. I see her whole family. Her son's got a little bit of that too. So now let's back up to what they were doing from a clinical like input, right? Stretch your gastroc, your Achilles, plantar fascia, put you in a little bit of dorsiflexion all day long. I mean, she has enough dorsiflexion to where, we're talking like 50 degrees, if not more. And then we think about how much neural tension you can create and then out of valgus load. And now we're starting to maybe see where we're going. Notable atrophy over gastroc soleus complex on the left. She's been in a boot for 5 months. That makes sense.
5 months or 5 weeks?
Sorry, 5 weeks. Good call.
I was gonna say, whew, that's a long time.
Could have been both and probably would have been the same. Tarsal tunnel test positive with slight edema over posterior tibialis tendon on the left. So you can feel like that tendon has just like edema around it. And as soon as I touch it, it's tender. If you push just generally anywhere in the tarsal tunnel, it creates numbness and tingling in her foot. Like that's the most positive tarsal tunnel test you're going to get ever, besides the tap, right? Like a Tinell's tap, tarsal tunnel. Tenderness to touch over the medial and lateral aspect of tibio-talar joint. So remember the edema was over the talocalcaneal joint. No pain there. So you go up to basically your ankle, if you're not a clinician, and you poke in on both sides, medial and lateral, really, really sore in that joint space, right? So now we have somebody that's doing what? They're hypermobile in all directions. She has a preferential kind of like dive in through ankle mortise joint, right? Rear foot valgus. She's just loading the snot out of that joint. So no wonder it's got edema in it, right? Like if you looked at like, that's one thing we didn't bring up on Sloan's case. Like she saw acute inflammatory findings externally, but on most gymnasts, you're probably going to see, insertional apophyseal inflammatory signals, just like basketball players with patellar tendons, runners with, medial tibial stress. Like, so then it, gets into this scenario where she has no signs of external inflammatory, happenings, no redness, no swelling, no heat, anything like that. She never has. This is where like all of these just lead you the same way. This is a case where like everything points to the same thing. So resisted eversion of that left side creates pain. So right, ankles everted, you resist eversion, creates pain on the medial aspect of her foot. You resist dorsiflexion, medial aspect pain. You resist inversion, no pain. So you're offloading the nerve, you resist it, there's no pain. Like it's just everything's pointing to the same thing. Tender to touch over the medial aspect of tibial plateau and with slight edema. So one thing I didn't put in the report here, she was tender at the kind of medial aspect of the lower third of the tibia, which is like shin splint land, right? Where saphenous nerve goes up. There's, again, if you look at the kind of anterior medial aspect of the anterior tibial plateau or the anterior aspect of the proximal tibia, little puffiness there. And you're like, well, why is all this stuff swollen, right? If there's not some injury, you can have like a neuropraxia kind of like swelling that goes on from that nerve that being irritated for so long. You poke in that part of her knee, lights her up. She goes, I didn't even know that was tender, right? And anybody would see that's a little swollen. And then loss of space between the first 2 digits on her left foot. So normal space between big toe and second toe on the right, left foot is just closed down. So we see, valgus load, closed down. What do we think is not happening? Not using any of adductor hallucis, all the things that pass through the tarsal tunnel are getting beat to hell. So they're probably like shutting down or inhibited. So this is where, it's kind of like Daniel's case, the functional audit, it's gait, right? I don't know if pain's causing that, or if that's what caused it, but I got to get her walking on. That's what I told her. I was like, that's our goal. Like, you have atrophy, you have pain when you walk. She can toe and heel walk just the same as walking as pain. Like, nothing changes. It's just walking. I'm in the kind of camp now with her that like, we just have to get her back to normal. I think she had a little probably peripheral nerve irritation entrapment from running and moving furniture. And we'll find out the low back stuff here in a second. And then she just got thrown in a boot and rested and made it worse. So she sent me a message in between the first visit and the second visit via our app. And she said, by the way, I was talking to my collaborating physician, which is the physician that she works for. And I've been dealing, it's just so funny that she had asked somebody, I've been dealing with low back pain for over 2 years. Remember, I asked 5 times, and it took somebody else telling her, yeah, you're always bending over, just rubbing your back. Which I already kind of went there because she had pain all the way up through the saphenous kind of obturator tunnel. So then the functional audit, gait, pain audit, gait, palpation, and life. I hate to say that, right? There's not a very specific, it's can we just get you out of pain by getting you back to walking, get your foot to function? I don't know if that toe space closed down while you've been in the boot, if that's how it was before. I have no clue. And that's the hard thing here. So diagnosis, honestly, lumbar radiculopathy with PNE or peripheral nerve entrapment, a peripheral nerve entrapment by itself, true tarsal tunnel syndrome, way off in left field, stress reaction fracture, right? Around some cuneiform, navicular. I highly doubt that, but there's edema on MRI. So you can't say that's ruled out completely. I don't think that's it because it should have gotten better by now. So going through treatment, obviously we adjust her low back. We, said with the restrictions that we found on palpation, this is a hypermobile person. So we got to get stuff moving specifically. We do some lumbar extension on the first visit. She gets up, walks around, says it's better. I'm not completely sold, right? She's looking for a fix. So there's a big psychological component. Soft tissue, we do some cupping dynamically with some lateral lunge stuff or DTM, says it's even better. And that's going from medial knee, medial ankle. Rehab wise, we did some lumbar extensions. We did some, the first visit, we did some DNS hanging. We're just trying to offload her foot. We taught her about short foot, and I sent her home with, I taped her foot too, just for kind of feedback through that tarsal tunnel, but a short foot single leg deadlift because she could do more than other people could. All right. She kind of had a little bit of foot function. So it's you just got to be doing a lot of this stuff. Go barefoot as much as you can tolerate. No boot, right? Which is, again, probably out of my scope, but I don't really care at this point because if something's bad medicine and you can dictate it is, and you're not just I don't agree with it. Bad medicine is putting somebody into a dorsiflexion brace that's bait and 9. And then saying that's going to improve outcomes. No, I don't agree with it. No boot, toe yoga, and calf raises if that doesn't create pain because she has atrophy. We have to get function back, but I was that may drive pain, so just play around with that. And then the extended plan is improve foot function, stiffen her tissues if she wants to run. Because I asked her in the first visit, because she's dealt with this for now 6 months, we would categorize it as what? Chronic pain. So it's you have to come up with a goal outside of getting out of pain. And she actually brought it up on her own accord. She goes, hey, you asked me to come up with a goal. It's I want to be able to walk multiple miles without having to think about pain, not just be able to walk without pain. And then I want to be able to run. It's okay. So we have to stiffen her tissues to create better energy return so she doesn't collapse through that ankle. Some central stability stuff, and then sleep. So that's probably, she wants to get off of these, this was self-reported, get off those sleep medications, sleep better. I think that's a huge thing for just pain relief, losing weight, all of her other goals. So she can be taping her mouth shut and seeing if she can get off the CPAP. Because what my thought is there, she got on the CPAP. She's had sleep issues her whole life. She had a sinuplasty, rhinoplasty, probably never changed function. It's no different than somebody have a lumbar fusion and they're like, you don't need PT. Just go about your business. We just fixed it. Well, you didn't change breathing function. Now you're using a CPAP and just forcing O2 down your throat every night. Like, and she even agreed that she's not very adherent to the CPAP because she doesn't feel like she gets benefit. So long-term is really like diving back into like health issues, maybe leading to overall like peripheral sensitization. But I'll give an update on that. And whenever we do the next one of these, sound cool?
Yeah.
Monica.
So I was going to talk about radiculopathy, but I think I just changed my mind.
Due to what?
Well, I have a case. I just saw her yesterday and I called her today. And it's very simple, but it was kind of rewarding. So I feel like I should just talk about that.
Yeah.
But I will say, as a new doctor, it was really cool to see a true radiculopathy with weakness, like heel walk, toe walk, like literally could not maintain dorsiflexion. So we learn about it, but you don't really see it until
You get excited about other people's pathology.
Yeah, I was like, this is awesome. This guy's got radiculopathy. Okay, so anyways, so this is my last patient of the night yesterday. Woman came in, she's got left-sided neck pain and migraines. And in her intake form, she said it was associated. She was like, neck pains associated with migraines, something like that. I don't have any notes, so I'm really trying to remember. She comes in, she's very thin, heard about us from a friend of hers that also has migraines or something like that, and thought she'd give it a whirl. So she comes in right off the bat and says, I live in Haiti for 9 months out of the year, and I really want something that I can do on my own and try and manage all of this on my own. And I heard you guys do rehab exercises, and I'm hoping to be able to take that with me to Haiti because she teaches in Haiti. So I really appreciate that. She's been to multiple chiropractors before. She's done light therapy only by a chiropractor.
When she's literally telling you what her goal is.
Yeah, which is awesome.
Yeah.
So like a great patient for us.
Mm-hmm.
She starts telling me about her migraines. She gets migraines like 3 to 4 times a week. She's sensitive to odors. So odors can trigger it. Anything can trigger it. Fatigue, stress. Just random things throughout her day can trigger a migraine, but she only has her migraines at night. So that was a little weird.
Does she drink?
I don't think so. I didn't specifically ask, but she doesn't seem like the one to drink.
I'm just curious. Why did you say that she's thin? Why did that matter? General presentation of the person?
Yeah, well, she's
like, does she seem frail or is she just thin? I was just curious because you threw it in like as a physical.
Thin. Well, I had to keep that in mind. I made a mental note that she was very thin.
That's why I was asking, because it was just kind of like, this patient came in, she's thin. And I was like,
she's thin. She's very thin.
Yeah.
She use a good lotion to keep young looking though.
You know what? She lives in Haiti and she's lived in the South. I don't know if she uses sunscreen, but I hope she does. She's also
Monica's very into dermatology.
She's very fresh. She's fair. Well, not fair anymore. She's freckled tan. So she's got red hair.
Yeah. I was just curious.
Yeah. Maybe that'll be in her past medical history, maybe. Well, she reveals that she's osteopenic. And she said one of the spots is in her neck.
How old is she?
She's 56.
Okay.
And she's kyphotic. A little bit hyperkyphotic, I would say. So I'm like, does this lady have a compression fracture somewhere in her spine? But she doesn't. Hopefully not. Not that she's aware of. Anyways, she can't turn her head to the left more than 45 degrees. Turning to the right is fine. She just feels tightness. She didn't have a migraine when she was in the office or any sort of headache. She's on a few medications. She's on a nightly medication for preventative for migraines, and then she's on a rescue medication for migraines. So if she wakes up in the middle of the night, has a migraine, she takes the rescue one, and then she's able to go back to sleep. Classic migraine with aura, and then all of a sudden neck pain. Neck pain doesn't travel. It travels like maybe into her trap a little bit and then up her neck. So on exam, I was mainly looking at her left rotation. So left rotation, I mean, if you think about 45 degrees, like you're not moving that much.
Yeah.
Right was fine. The only thing that was really positive on exam was max femoral compression towards the left side. I believe. Yep, towards the left. I did a movement screen for her cervical spine. Protrusion reproduced the pain. So chin protrusion, retraction was clearly obstructed. Extension wasn't great either. Flexion was okay. So, of course, I feel like I'm the MDT person right now. All of my cases are MDT, but I have reduced in retractions. And then all of a sudden, she's like, yeah, I have some tingling down into my hand. And I'm like, oh, crap. I'm like, all right, stop doing
Especially
that.
at 6 o'clock at night.
Yeah, at this point, 6:30, almost 7 o'clock. I'm like, oh, goodness. I just gave this lady worse symptoms. So we did I made her do the full 12. I was like, all right, just let me know if the tingling gets worse. She did that. We actually improved rotation to the left a little bit, but she still had discomfort. And instead of going into a different direction, I feel like we often forget just changing the position. So I laid her down on her back, head dangling off the end, and I did the retraction for her in supine. And then we sat her up. She was able to rotate about like 70 degrees or so. And she was like, oh, that's a little bit better. And I was like, do you have any tingling? She's like, nope, no tingling at all.
Fair enough.
Yeah, we did more. Just kept doing it. I had her do it herself. So her essentially just pushing into that twin retraction position on the table to show her that she can do it at home without her head like dangling off the bed. She got back up. She rotated like 90 degrees. She's like, I can almost get my head turned up past my shoulder. And I was like, this is awesome. So she thought it was great. And I was like, sometimes I'm a magician, but you know.
Sometimes you wear capes.
Yeah.
Sometimes I steal Daniel's capes, but so yeah, she was like, my neck feels really good right now. And I was like, this is great. All I did was adjust her T-spine that day. I didn't want to touch her neck, especially someone with migraines. I don't know if you guys feel this way, but someone that's really like getting migraines that constantly, I don't want to trigger it. I don't want to be that person. We did 3-month prone with her out here. And I called her today, not too long ago. And I was like, hey, let's call her, I don't know. Betty. Hey, Betty, how are you feeling? She's like, oh, thank you so much for calling me. I feel great today. It's like, my neck barely hurts. I only woke up once last night, which is my usual, but I didn't have a migraine. And I was like, whoo, this is great. Woo. So she's been...
Ric Flaired her on the phone.
I was really excited. She was really excited. She's like the sweetest small woman who just wanted to be able to treat herself essentially in Haiti. But yeah, I see her next week. And so I'll keep you updated on the migraines. She's had a ton of different treatments and studies. I mean, she's had migraines since she was 16. And then the neck pain has just been a gradual onset since then. So
I'm curious on two things. Is she mobility wise overall? I know she's kyphotic and stuff. Is she hypermobile or no?
I didn't test it.
Yeah.
When you were talking about the bite, I was like, I should have tested it.
And then most migraines show up around that age, right? Like puberty, kind of early adulthood, especially female. So.
Looking at her, I mean, I would assume that she's hypermobile.
Yeah.
Especially with how much rotation she was able to gain. Like it was really going past 90 degrees.
Yeah.
So yeah, I don't know if I would be adjusting her neck.
Yeah.
I would check if it needs to be, I guess. But
So I'm curious, what's the long-term like plan? Like, what are you going to be working on?
Long-term?
I mean, I guess she's leaving as well, but like beyond just like symptom removal, MDT, like where do you think like some of her biggest movement kind of issues are?
Her thoracic spine, absolutely. Just, I think overall stability. She also has back pain that I think I kind of want to dive into as well. But she's hitting the gym. She's trying to gain strength. So we can also incorporate some stuff like that.
Yeah, she needs to, osteopenia. So
Which she's on a medication for.
Yeah.
So she's got a lot of things going on. But
I kind of want to throw this in there real fast. Every once in a while, Beau and I, you should just be a fly on the wall sometimes for like Beau and I's dinners. But we get into the conversation of like,
there literally flies on the wall in the summer.
Oh man,
We need to screen the porch.
but we talk about like life's purpose and our purpose, our
Easy, light subjects.
Yeah,
like
very-
dinner gets real deep. Usually go to bed depressed, migraines.
well, like maybe we have
attractions.
maybe we have a not so stellar day and we start to kind of, I think anybody would do this in life, but just a question sometimes, like, are we doing what we're set out, like meant to be doing, or should we be doing something else or something different, something more? Say you just see a bunch of, I don't want to, people that have very like low grade knee pain that we want to help and we want to see success with, but maybe it's just not, and they get better, but it's like, it's not the life-changing moment like someone with a migraine. And what I'm getting at is you're going to have these patients that you completely changed their life. So someone that's had a migraine since they're 16, that's massive. And so I think that's really cool for you to experience, and don't take it lightly what direction you've led her. Like, that's really, really cool that you've had that impact on her.
Now, I don't necessarily know if that's going to cure her migraines,
But it's
but
a
maybe
step.
it'll help.
Yeah. That's a step.
Next time I'll talk about a migraine case, and then it would use themes every once in a while. But one thing that I'll challenge too, because Sloan's saying, like, man, you changed your life. Like Lynn Fay said this on Gestalt podcast the other day. Like, he said, I'm not looking to change people's lives. I'm just trying to help them be healthier. But he said, I have to be in their life more often to do that. So like somebody like that, like she just voiced like, I'm not around all the time. But like, obviously, so that's a limitation, but it's like, obviously there's a lot of like stuff that you could do. I mean, she's osteopenic, she's kyphotic. Like, we need to get her moving, need to load her musculoskeletal system, load her, axially, do all those things. Like, that's life-changing, right? Not just like, oh, I can turn my head, my migraines, but like, dude, I'm doing things I never thought I would do way longer. And I think that's the harder play, is like the whiz bang, like the guy gets off the table, my hips felt better. And no, the hard play is it still like that 2 years later, right? Or does he have that hiccup? Got worse. I rode to, North Carolina for 6 hours. My hip's been terrible since. Not can you get him back out of that, but has he learned enough now that like, I just keep going, like, and I can get better and I go over it and now I'm better than I was. And that's, I think, the really like life-changing is like, that's what we're trying to do, is teach people. Like, you're teaching her like, like your migraines may be associated with that. They may not. But like, if you get moving overall, you have more options to get yourself out of pain instead of the medication we've been taking since, 16, 17, whatever, that rarely helps. And they usually just keep switching to see if it does help.
I want to throw this in there that I don't walk into a patient room every day going, I can't wait to change their life.
Oh, she's told me that. It's like dinners that she's talking about.
I mean, you just followed that quickly up by that doc's quote of, I'm not looking to change people's lives. And that's not what I'm doing every day. But
I know.
But when those moments happen, I think we should value it. And
I do. All I'm saying is like, don't get caught in that moment.
Like you're hanging your hat on that one success.
Like, not that you're hanging your hat on it. Like, I think we get fooled. Like,
you're stopping too soon. Yeah, you're quitting exactly. You're finishing the race too early.
Like, awesome. And then you're like, dude, you're awesome. And then 5 visits later, they're still awesome. And you're like, did you change what you set out to change? That's why I was asking about, like, with that knee pain, did it limit her? Did it change stuff? Can we get her out of pain and see what it limits? I mean, that's what we all said today. Like, okay, what's the next thing we're working on? What's the next thing we're working on? What are we going? And I'm guilty of it, just like all of us. Like, can you keep going to make enough change, or just be a part of their life for a long enough time that like they get it, right? Like, you're supposed to do, a human body's supposed to do certain things. Your body may not do these things. You have more challenges than somebody in this area. Like, and I think that's what, like, I've missed out for like first part of my career. It's like, just like
cutting things way too short.
Boom, 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 boom.
Yeah.
Like, oh man, your ankle's moving awesome. Well, guess what? There's like other stuff to work on that may drive your ankle back into that pathologic or aberrant movement or dysfunction, right? Yeah. See, this is what our dinners end up like. Then I go to bed all sad.
They're heavy. They're heavy.
Any last comments?
Other than like maybe a depressing story from Sloan about somebody that like you'd heard of, and she's gonna let you know. Now that I've kind of learned that, where she's gonna be like, "Did you hear about XYZ?" And then,
I always have the sad news.
So Sloan's theme for those listening or watching is Sloan usually is staring at her phone and she'll go, "Oh my!"
Terrible.
I'm not saying no. Okay. I'm saying when you say these stories.
Okay, yeah,
right.
When you say these stories, you're usually staring at your phone. You go, "Oh my god!" And she just yakking on a bone.
She put it in my pocket. I was so impressed.
She'll usually be looking at her phone. She'll go, "Oh my God, did you hear about this?" I'm like, "What are you talking about?" She'll tell me some random story about things I don't know, people I don't know, and act like it's just, which you're a bleeding heart. I appreciate that. But I'm like, I don't want to know that because that's just adding to my like burden list. I got to come in here and listen to everybody's aches and pains.
Burden list.
Like, I don't want more of that.
I feel it at such like a
I want
visceral
stories
level.
about puppies and puppies that can fly and shit that's not even real. That's what I want to hear at dinner time. All right. That's what I want to hear next time for everybody.
I bet you if you were to ask the public, just from our public perception of who would probably bring those stories to the table, I bet you they would say you versus me.
Yeah, but that's, remember what I am on the personality test. High emotional, high intellect. I know better.
I'm about to say, I'm always going to bring the stories that make everybody like lightly smile or laugh.
Yeah, Daniel's definitely sending us Instagram videos of, what was one yesterday?
It
was hilarious.
What is it, the carbonara effect?
Yeah. Where he's like a physician with a guy with like neck pain. He's like, these traps are so tight. Sometimes they can cause hallucination.
And I'm like, oh, did you hear about that 17 car pileup?
Yeah. And I'm like, what the hell?
I do have one thing for everyone to think about.
Yeah.
Before you say that, well, Monica's going to send me something like a cookie in town. And I'm like, oh, I really want to eat that.
Yeah, we've got lighthearted,
Trader Joe shopping secrets.
depressive, and then I'm gonna try to blow your intellect up. Or everybody's like,
It's very philosophical.
All right, here we go. Does a straw have one hole or two holes? Think about it. Me and Daniel has
One
well, then you got. So what do humans have?
Ooh.